Hello and good evening, ladies and gentlemen. Bonjour. My name is Michael Balarjan, Senior Advisor to the Canadian Council of the Blind and Project Co-Lead to the Cost of Vision Loss and Blindness Study. On behalf of the Canadian Council of the Blind and our partners Fighting Blindness Canada, the Canadian Association of Optometrists, and the Canadian Ophthalmological Society, welcome to our summit on the impact of COVID-19 pandemic on eye health in Canada. Folks, it's my honor and great pleasure to introduce a true friend of the vision loss community, Rosie Childershos, representing the summit's presenting sponsor, Bausch & Lomb.
Good evening and welcome to the summit. My name is Rosie Childershos. I'm the Director of Market Access and Government Affairs for Bausch & Lomb, and it is my sincere pleasure to welcome you to the summit on the impact of the COVID-19 pandemic on eye health in Canada. This is a timely continuation of the conversation from last May's report on the cost of vision loss and blindness in Canada. The report and the conversations such as the ones we're having today are ensuring that vision health patients are being seen and that their concerns on access to timely care are being heard and addressed as a priority. It is urgent that vision health patients get the care they need to ensure they are able to maintain their health and have a high standard of living. I'm sure you will join me in thanking the Canadian Council of the Blind and their partners Fighting Blindness Canada, the Canadian Association of Optometrists, and the Canadian Ophthalmological Society for their ongoing essential work that is making a positive difference to Canadians with vision health needs. Now let's go to Michael, who will lead us through today's inspiring agenda that is sure to inspire the vision health movement in Canada.
Thank you, Rosie, and thank you, Bausch & Lomb Canada. COVID-19 has impacted all Canadians, including people with living vision loss and blindness. Deloitte Access Economics, authors of the Cost of Vision Loss and Blindness in Canada report in 2019, investigated health data between March and December of 2020 to determine the impact of COVID-19 pandemic has had on vision health in Canada. Today's summit will present the results of that report, what you will hear about, and more. 8 million plus Canadians are living with eye disease that can lead to blindness. 1.2 million Canadians are living with vision loss. 143,000 necessary eye surgeries were canceled or delayed in 2020. There were 3 million fewer optometry visits in 2020 compared to 2019. Longer wait times for surgery will result from COVID-19 in a $1.3 billion increase in the cost of vision loss, and it's expected to take 2 years to clear the additional backlog of eye surgeries, including cataracts. 1,437 people lost vision due to delayed eye examinations and treatments during the pandemic. 3/4 of the cases of vision loss in Canada are reversible, preventable, or treatable if diagnosed early. How are eye professionals, policymakers, and people living with vision loss responding? What needs to be done? This evening's expert panel will discuss the implication, action plans, and recommendations for vision health professionals, health policy makers, and citizens of Canada. We have gathered a panel of Canada's health leading leaders. Dr. Colin Mann, President of Canadian Ophthalmological Society. Dr. Harry Bonsack, President of the Canadian Association of Optometrists. Louise Gillis, immediate past president of the Canadian Council of the Blind, and Doug Earl, president and CEO of Fighting Blindness Canada, will discuss the report and its implications on vision health. Your panel will discuss how their various professions and fields, optometry, ophthalmology, and vision loss community, advocacy, and research have been affected by COVID-19. Regarding your questions, you may ask your questions to any of the speakers using the chat function on your control panel. At the end of the session, we will answer as many as possible. But first, we'll lead off with Dr. Keith Gordon, lead investigator and senior research manager at the Canadian Council of the Blind, who will present the study's findings. Keith?
Thank you very much, Michael. Thank you for giving me this opportunity to present the results of our study here today. The study is an addendum to the study that the Canadian Council of the Blind commissioned in December of last year. The initial study was conducted by Deloitte Access Economics and reported on the prevalence and cost of vision loss in Canada using 2019 data. The results of the study were reported in May of this year, and they were the first data of this type to be presented in Canada since 2007. Canada has had a tremendous shortage of availability of good, solid data on which to base planning in eye care, and it was important that this study be done. Briefly, I'd like to just give you a very, very short overview of what the results of the initial study were, and then I'll move on to the effect that the pandemic has had on these results. The initial study showed that there were an estimated 1.2 million Canadians living with vision loss in 2019. This represents about 3% of the population. What surprised us in the study was that we found that the number of people who were suffering from severe vision loss was quite low, and there were about 50,000 people who fell into this category. Most people had moderate vision loss, and about 2/3 had mild vision loss. Just over half of the people with vision loss were 65 years of age or over, and that's not surprising. And we found that about 1 in 5 people over 85 had vision loss. The reason I put that down, it sort of means that we all know somebody who's experiencing vision loss. We all know at least 5 people that are over the age of 85. And so we need to be sensitive to a lot of the issues that people with vision loss are facing in general and were facing particularly during the pandemic. Over and above these findings on the number of people with vision loss, we found that there were about 8 million Canadians living with an eye disease that may lead to blindness. These are people who have been diagnosed with these 4 major eye diseases, but haven't yet shown symptoms of vision loss. So they're the people that have to pay particular attention to getting their eyes examined on a regular basis. And we felt that this is a population that is particularly vulnerable during the pandemic if they can't get to see their eye doctors and get early diagnosis of their eye disease. Initial studies showed that the total cost of vision loss in Canada in 2019 was just under $33 billion. That's billion dollars, consisting of a total financial cost of $15.6 billion and a lost well-being cost of $17.4 billion. The well-being cost is not a financial cost. It's not dollars that you can put in the bank, but it is a metric that's used by health economists to assess the impact of vision, the economic impact of vision loss. The financial cost of vision loss was estimated to be about $10,000 per person with vision loss, or about $415 per Canadian. In this report, for the first time, we're able to show what the cost of falls due to vision loss were. There have always been healthcare planners have known what the cost of falls were, but nobody has ever assessed how much of that cost was due to vision loss. And for the first time, we estimated that and showed it to be about $105 million. The annual cost is $105 million. To summarize our findings by looking at what would happen if we basically did nothing. If we continued doing what we were currently doing, if nothing else unusual happened in the environment, we estimated that in the next 30 years, we would go from having 1.2 million people living with vision loss in Canada to around 2 million. But as we all know, along came the pandemic, and we felt it was really important to reassess what these projections are going to be and to assess what impact the pandemic itself had had. The preceding results, the results I've just presented, were all pre-pandemic. So what impact did the pandemic have? Well, here are our key findings. These are new results not presented before. We show that just under 3 million fewer visits were made to optometrists in 2020 compared to 2019. Optometric offices were closed in many provinces for about 3 months, And once they opened up again, optometrists weren't seeing as many patients as they were before the pandemic. So all in all, we estimate that all adds up to about 3 million visits that were not made to optometrists. We made an estimate as to what the delayed eye examinations and the delayed treatments, what impact they would have on vision loss, and estimated that there are about an additional 1,437 people who experienced vision loss in 2020. I think every ophthalmologist, I've spoken to a number of ophthalmologists that can tell you that they have now run into patients who have lost vision, who didn't necessarily have to lose vision, but they didn't see their ophthalmologist during that time. We estimate that number across Canada is at least 1,400, it's probably more. We estimated that there are 143,000 eye surgeries that were cancelled or delayed in 2020. So there were about 143,000 eye surgeries missed or delayed in 2020. And we estimated that the wait times for cataract surgery increased by 31 days in 2020. So this is an additional increase over and above the wait times that people were experiencing. So on average across the country, people had to wait an additional month to see their ophthalmologist for cataract surgery, and the actual amount of time depended on where you were in the country. We did a calculation on how long we thought it would take to overcome the additional backlog of cataract surgeries caused by the pandemic, and we figured that that'll be about 2 years. Actually, this was a calculation done at the University of Toronto. I shouldn't claim that we did it, but that was the estimate. 2 years to clear the additional backlog of cataract surgeries. And as it estimated, an additional $129 million per year will be required to clear the backlog of cataract surgery over the next 2 years. So this is over and above what is currently being spent on cataract surgery. So we're encouraging governments to put more money into it to overcome the backlog, because people have lost vision due to cataracts. Now, when you look at the cost of vision loss and blindness, we talked about what it was before, and we estimate that in the first year of the pandemic, in 2020, there was actually a reduction in the cost of vision loss to the healthcare system, and we estimate that that's about $730 million overall. So that's due to an underutilization of services. We know that people weren't going to see doctors, so the governments weren't paying out those funds. But there's no such thing as a free lunch, and that is going to rebound in the next couple of years. And over the next couple of years, we figure that there'll be an increase in wait times for surgery that will result in a $1.3 billion increase in the cost of vision loss over the next 2.5 years. $253 million of this will be direct healthcare system costs, and about $1.1 billion is due to the loss of well-being. And we estimate that the cost of vision loss will be about $500 million higher annually from 2021 to 2023. Is this all valid? We felt we had to have some sort of measure as to what we were experiencing, and to do that, we decided to compare with the United Kingdom, where a similar study was done. The UK has a population that's approximately double that of Canada. It's 67 million compared to 38 million in Canada. In the UK, they estimated that 2,900 people lost vision. We estimated about 1,400. That's about half, so that's right within the ballpark. We showed in the UK that there were about $4.3 million fewer eye examinations. In Canada, it was 2.9 million. That's a little higher in Canada, but not significant. Reduction in eye surgeries was about 235,000 in the UK and 143,000 in Canada. It's also within the ballpark. The reduction in the cost of vision loss in 2020 in the UK was £778 million. In Canada, it was $730 million. The pound's about 2 to 1 on the dollar, so that is also within range. But the next thing we found, there was a significant difference in the reduction in anti-VEGF injections. Those are injections that people are receiving for macular degeneration and diabetic retinopathy. In the UK, they showed that there were about 15,000 fewer injections. In Canada, we showed that there were about 70,000 fewer injections. So we're much higher than they are. And we started inquiring into this and found that the main reason for this was in the UK, ocular injections were given emergency status at all hospitals. So you could still continue to have your eyes injected in the UK. In Canada, this was not the case. Some doctors were still seeing their patients and were still injecting their patients, but more were not doing it than were doing it. So that's really the only significant difference. In the UK, they estimate that the eventual added costs will be £2.5 billion higher over the next 3 years. We estimate it will be $1.3 billion higher over the next 2.5 years. And they estimate that it will take 3 years to clear the backlog on all services. We estimated that it will take 2 years to clear the backlog on cataract surgeries. So that's all of the health information and the cost information, the expenses, the economics. Back in April of last year, we did a study on the social impact of COVID-19 on people with vision loss. We were concerned that people with vision loss were staying at home and were experiencing a particular amount of stress. So we decided to survey a large number of people who were living with vision loss. And we found that there were high levels of stress. We found that sight loss made social distancing impossible. People weren't able to use a sighted guide, and that's because at that time people weren't allowed to go out on the street and stay within 6 feet of anybody else who wasn't their immediate family. So as a result, people were afraid of going out alone. They had difficulties accessing health care. They had fear of not meeting their financial obligations. They were afraid that they might get the virus, and so were we all. They were afraid of developing mental health conditions. They had significant feelings of being alone or isolated. And this is one thing that we then transmitted to a lot of the vision rehabilitation organizations, and they started contacting their patients on a regular basis in order to offset this loneliness or isolation. We found that people were afraid that the personal care workers coming into their homes were not using PPE. I think that was more the case at the beginning of the pandemic, but I'm sure some of that's still happening now. And overall, there was a deep concern that people may lose more vision because they weren't having the care that they needed. And we reflect that in a lot of the stuff I've just talked about. So in conclusion, the pandemic has had a major impact on eye health in Canada. People have lost vision as a result of the pandemic. People have missed having their eyes examined and have delayed eye surgeries. People need to return to their eye doctors as soon as possible to make up for lost visits. If there's one takeaway from our whole study, is that the need for patients to go back and see their eye doctors. If you had surgery scheduled and that got canceled, go and reschedule it. If you had an eye examination scheduled, go and reschedule it. It will take additional resources, both financial and human, to overcome the backlog of surgery and doctor visits. And I say human, that means we're probably going to need people to be working overtime and additional staff. The long-term impact on both individuals with vision loss and the costs associated with vision loss will be significant. People with vision loss have suffered more than most as a result of the pandemic and will need special care to overcome some of these effects. Vision rehabilitation organizations are aware of that and need to be sensitive to it, but so do eye doctors and all of us in the general public. So what does this all add up to? If we are going to provide the appropriate care in the next year or two and going forward, Canada needs a vision health plan. The federal government has promised a vision health plan since 2003 at the World Health Forum, and they've promised that at least 4 times since then, and nothing has been done. Not only do we need a vision health plan, we need a vision desk at Health Canada. And we have put together a petition to ask the government to do this. The petition is available at www.stopvisionloss.ca. And at stopvisionloss.ca, you can also get copies of all of these reports that I've mentioned. And we hope that you will join us in our campaign to get a vision health plan for Canada. Thank you very much. I am going to introduce Dr. Colin Mann, President of the Canadian Ophthalmological Society. Thank you, Colin.
My name is Colin Mann. I'm a comprehensive ophthalmologist practicing in Bridgewater, Nova Scotia. I'm currently president of the Canadian Ophthalmological Society, and I'm honored to be part of this panel for today's discussion. As you know, the COS represents Canada's medical eye doctors and surgeons and is the national authority on eye and vision care in Canada. We're committed to assuring the provision of optimal medical and surgical care for all Canadians by promoting excellence in ophthalmology and providing services to support our members in practice. Our membership includes over 1,000 ophthalmologists and ophthalmology residents across the country. We work collaboratively with government, other national and international specialty societies, our academic communities, our provincial partners and affiliates, and other eye care professionals and patient groups to advocate for health policy in Canada in the area of eye and vision health. COS is an accredited award-winning provider of continuing professional development through the Royal College of Physicians and Surgeons of Canada and is an affiliate of the Canadian Medical Association. I'm happy to be here today to discuss, from the view of an ophthalmologist, the impact COVID has had on vision loss in Canada. I was certainly deeply troubled to see, as you've heard, that an estimated 1,437 people lost vision due to delayed eye examinations and treatments in 2020. That number, indeed, any number, is too high. The silver lining, if there's one to be found, however, is that many of those impacted have reversible vision loss conditions. That is, we can restore vision given the opportunity and the resources. The effect of COVID on eye care in different parts of Canada has been really uneven. Some areas where the healthcare sector was already stretched thin or overwhelmed with patients needing surgery were disproportionately affected, as COVID-19 exacerbated those already difficult situations. Discussions with colleagues across the country have revealed an uneven landscape as different provinces and regions had very different experiences with the extent and impact of COVID-19 on the population and the healthcare system. That, combined with the fact that healthcare delivery is a provincial responsibility and approaches vary across the provinces and territories, has resulted in a significant variation in the degree to which COVID has affected eye care across the country. This vital report, however, gives us some insight into the aggregated pan-Canadian effects of COVID-19 with delayed or missed examinations and treatments. For example, estimates that wait times for cataract surgery increased by 31 days in 2020, with an estimated 143,000 eye surgeries missed or delayed in 2020. It is, as you've heard, expected to take at least 2 years to clear the additional backlog of cataract surgeries caused by the pandemic. The solutions to these backlogs are specific and unique to the individual regions and provinces, as the challenges are. The ophthalmologists in those areas are uniquely qualified and positioned to work with government and all the partners in the eye care team to address the backlogs and reduce the cost of vision loss. Ophthalmologists, health departments, and governments are in many areas working collaboratively on innovative ways to deliver the needed ophthalmic surgical procedures and care and reduce the backlogs. It's imperative that we all continue to explore those innovations and those new initiatives. It is, as you've heard, estimated that an additional $129 million per year will be required to clear the backlog for eye surgeries between 2021 and 2023. But the solution isn't just money, but how and where we spend that money. We also we need to not only put the resources, financial resources in, but we need to spend it smarter. As our population ages, we also need to ensure that we invest enough in our ophthalmology human resources. Governments across the country need to invest in training medical doctors and surgeons to fill the increased needs of the future, as well as the present. In addition, they need to ensure that there is adequate access to the required surgical resources. Those limitations are often not just the ophthalmologists, but the OR facilities and time, adequate nurses and ancillary personnel. These are needed to enable the trained surgeons to be able to provide the care so desperately needed. If they don't, more people will be impacted by vision loss in the future. The report tells us that an increase in wait times for surgery will result in $1.3 billion increase in the cost of vision loss over the next 2.5 years. 253 million of these costs are direct health system costs, and 1.1 billion result from the loss of well-being. That being said, the 2020 Conference Board of Canada report on ophthalmology in Canada demonstrated that ophthalmic interventions show a positive return on investment to society of approximately 3 to 1. That is, for every dollar spent on ophthalmic care and interventions, there's a return to society of $3 in both direct healthcare cost savings and indirect cost savings to society. Spending money to prevent the cost of vision loss pays dividends, not only to individual patients in preserving visual function and the associated independence and well-being, but to society as a whole, and it's financially prudent in the long run. It makes sense to make these investments, and the time is now. Finally, I'd like to reassure patients across the country that the ophthalmologists of Canada have been working diligently and tirelessly throughout the pandemic to meet your needs and will continue to do so. We have in many cases had to adapt and evolve our practices to accommodate restrictions and precautions that have been necessary, and we have, where possible, streamlined access through virtual care and have adopted and adapted new practices to allow care with all possible safety. One continuing challenge has been patients' reluctance to seek care or continue their care plan during the pandemic, as we heard Keith allude to. It's imperative that you as patients know that you can and should keep your appointments for consultations and follow-up to avoid unnecessary visual loss due to missed or delayed care. I would assure you that if you have worries or concerns, please reach out to your ophthalmologist or the members of your eye care team to discuss your care plan. Keep those lines of communication open. If your situation has changed during the pandemic with your vision, again, contact the members of your eye care team, seek that follow-up or that consultation. Ophthalmologists in Canada and the Canadian Ophthalmological Society look forward to working with all our partners and stakeholders in the eye care field to ensure we address these critical issues so everyone gets to see the future. Thank you for including me today on this panel, and I look forward to further discussion.
Thank you very much, Dr. Mann. I would now like to introduce Dr. Harry Bonsack, who's president of the Canadian Association of Optometrists.
Thank you. Good evening. My name is Harry Bonsack. I'm the president of the Canadian Association of Optometrists, and I'm pleased to be with you all tonight. I want to share with you what optometry has done to minimize the potential negative effects of this pandemic. Optometrists' offices were forced to close during the first lockdown from March to May or June of 2020, but were diligent to monitor calls during that time period and phone messages in order to look after urgent care patient needs. Optometrists were there during that shutdown to triage, to see, or to refer patients with urgent care issues to keep the burden off emergency rooms. Although some Canadians have been hesitant to see healthcare professionals prior to being fully vaccinated in 2021, many were comfortable to attend their optometry appointments as there were protocols implemented to maintain patient safety. Optometrists are continuing to practice as efficiently as possible while respecting COVID safety measures to address patient needs. Referrals are prioritized with the most urgent or vision-threatening ones being addressed directly to ensure priority patient care. The importance of comprehensive eye exams. We're encouraging Canadians to return to their optometrists for comprehensive eye exams to prevent potential deterioration of their sight. You've heard that said a couple of times tonight. Detection of progression from dry to wet macular degeneration, as well as macular fluid from diabetic retinopathy, are just two examples of causes for urgent referral. Retinal tears and detachments are also other examples, and there are many others. Optometrists have the technology and training to detect these earlier now and can refer these patients promptly for intervention. So if you have these issues, or even if you're not aware, do not put off your regular eye examination and do see your optometrist. Patients with conditions that put them at risk should be seen in a timely way. I believe optometrists are already doing so, having remained open during using prudent protocols throughout the pandemic since reopening. The challenge is that the backlog of patients waiting for care is getting longer. Optometry is positioned to help the group outlined in this slide get help, but timely access is the key. And some previously non-urgent referrals could worsen as a result of the wait and require more intervention by the time that they are seen. We need maximum efficiency within the system. And that could mean that family doctors and other health professionals, patients being referred first for primary eye care, perhaps to the optometrist, who can then determine whether the patient need to be treated or followed within the optometric setting, or if they do need a referral, how urgent that referral is, and making sure that that patient is seen in the appropriate time frame. The takeaway is the right practitioner at the right time. We have found that in many parts of the country, the move to have injuries and infections seen in optometric settings rather than the ER has continued after the early days of the COVID shutdown, reducing the burden on hospitals. There are a number of challenges in the vision and eye health sector as our population is aging. We will benefit from more cooperative collaboration with ophthalmology to improve efficiencies and help address these challenges. So I believe that optometrists can see a large percentage of their pre-COVID patients during the pandemic based on continued observation of clinical protocols developed at the outset. The vast majority of optometrists never dropped the requirement for masks and sanitizing as exams put patients and staff in close quarters together. These kept both patients and staff safe to get required care, and we've maintained in-person care since returning in May or June of 2020 and have, where numbers allow, even increased the percentage of normal patient capacity. All Canadians require access to quality eye care from birth to their senior years, and it's an investment that pays significant dividends in terms of higher educational achievement, enhanced quality of life, and with corresponding reductions in system costs. So with that, I thank you for your interest in minimizing vision loss and the necessary steps to improve visual outcomes for Canadians during this COVID-19 pandemic.
I would now like to introduce Louise Gillis, who's the immediate past president of the Canadian Council of the Blind.
Thank you, Dr. Gordon. I'm here as a patient. I too have had some struggles through COVID, but so do many others. And although they've mentioned the number 1473 patients that have had side effects or vision that worsened, we don't know that that's the accurate number. There could be many more, because many people would be afraid to go or just ignored it and ended up just not having any treatments whatsoever. So those would not be reported. But for my case, and I'm sure this is very similar for others as well, I have been seeing an ophthalmologist for many years for glaucoma, and had seen my ophthalmologist in July. At that time, the ophthalmologist was closing this practice out, moving to another city. So therefore, she was referring me to an incoming ophthalmologist who was supposed to come early fall. That doctor was not able to come or to begin his practice until January. And in November of that year, 2020, I felt that my pressure probably was increasing. I was having more issues, blurring vision, and more difficulty in discomfort in my eyes. So, and having had glaucoma for well over 35 years, I was quite aware of what the feelings are when your pressure increases. So I tried to make connections with people. I could not get to see an ophthalmologist because their practices were full, and I was waiting for one to come, so I had to wait. Anyway, finally, I could not make contact even in January when this doctor arrived. I could not get a number to speak to his office or anything to find out where my referral was in the pile of patients he had to see. So it took a lot of my own personal advocacy to get going. So I had somebody drive me to one of the ophthalmologist's office so I could speak to somebody in person and find out what is going on. Eventually, after some time, I did find where this doctor's office was, and I went there. By this time, it is early February, and went to the receptionist. She said, "Well, you're not on the list until June." And I said, "Well, I can't wait until June. I feel this is urgent." So she started looking and thinking, well, we'll see what we can do. So anyway, this was on a Tuesday, and she went looking on my files and on the referral slip that she had, and discovered that yes, I probably was quite urgent. And she then looked and booked me 2 days later for an appointment. Indeed, my eye pressure was up. It had increased quite a lot from what it was in July, and there was resulting vision loss from that. So started on a new regime of treatment, which after a few weeks discovered that I was allergic to the treatments and was not able to continue on that. So it took another while for that to clear up and to try a different treatment. So now I'm on a new set of drops, and my vision has stabilized in the fact that I don't feel the pain and the soreness that I was having before, or the blurring of vision as badly, but it's still not as good as it was like a year prior. So as a result of COVID, because this doctor was not able to come into the country due to COVID restrictions and whatnot, then I was one patient. How many more patients like me have lost eyesight because they did not get to find a doctor or anybody to look at them? And not only that, the fear of going to a doctor's office, coming out of your home, and it just, people were frightened to not even try to make an effort to go and do something to get their eyes checked. Whether it be with an optometrist or an ophthalmologist, people just had that fear of, maybe I'll get COVID, and COVID is worse than being blind. So they just let things slide that way. But for me, I'm quite pleased now, because the new ophthalmologist that I do have has been seeing me very regular, like on a 2 weekly basis, and now I'm gradually got up to a 2-month basis. So hopefully other people, once they get back into treatment, can do better, and in cases of other things such as AMD or cataracts may end up regaining vision. So please, for all the people out there who are listening on this, make sure that you continue with your eye appointments, and if you can't get it, be an advocate for yourself and get out and do it. And if not, check with other organizations or people that can help you do it if you don't know the method of how to go about doing that. So it's really quite an urgent thing to this. Just because I'm growing old doesn't mean that I should be going blind. And that's a myth that everybody has. And I want to keep my sight as long as I possibly can. Just make sure you get your checks done and listen to the numbers that these gentlemen before me put before you as to how serious this situation is. And let's get a national eye health plan and a desk at the Health Canada. So thank you for your time.
Thank you very much, Louise, for putting a personal face on these numbers. Numbers are numbers, and until you actually hear an individual story and start projecting those many individual stories out, it doesn't have the same feeling, and thank you for giving us that feeling. I'd like now to introduce Mr. Doug Earl, who's president of Fighting Blindness Canada.
Thank you, Louise, for sharing that story. I think it really does bring into context all that we're talking about, the impact of COVID and the pandemic on eye health. And really, the fact that almost 1,500 Canadians experience vision loss, that over 3 million or almost 3 million visits did not occur, that 143,000 surgeries, almost 70,000 eye injections did not happen. I think it really does point to what Fighting Blindness Canada sees as our mandate around funding of research, but also access to treatment. The government of Canada has promised 4 times since 2003 that we need a national vision health plan. They've made that commitment. It's been far too long. They've not started the process. And I think this report, this impact of COVID, points to what happens when we don't have a national consensus, when we don't have a national vision health plan. When we looked at the numbers, when Keith and Michael and I talked to the team in the United Kingdom about their report on the impact of COVID, and we saw that stark contrast to how anti-VEGF eye injections were treated compared to what happened in Canada, I think it says an awful lot that if we had had a national vision health plan, the conversations, the planning would have been undertaken. We could have, like the UK, identified these eye injections as a part of an emergency care program. You know, there are parts of this country that don't have wait times related to cataract and other eye surgeries because of how the system dealt with the pandemic. There are other parts of the country that didn't have this national health plan or their own vision health plan that reacted in a different way. And as a result, Canadians are losing sight. And Canadians are not getting diagnosed early when research has delivered 3 out of 4 could receive a treatment that could stabilize their sight. And if early enough in diabetes, for example, related vision complications, we could repair the damage using that treatment. This is the impact that happens when we do not have this vision health plan, when the system is working in its own, in its regions or within its own disciplines. And the end result is that it impacts patients. And I think it's very telling. You know, the cost of well-being is a way of measuring the impact on people's wellness. And Louise sharing her story, there was a lot of well-being as well as sight that over the course of that time was impacting the quality of her life. And that's why it's so important that I encourage you to visit stopvisionloss.ca, to sign the petition, to help add your voice, to make sure that Canada honors its commitment to Canadians, the government of Canada honors its commitment to Canadians, that we have a national vision health plan, that when whatever happens as we move forward through this pandemic or into the future, that at least we have a framework in order to ensure a public health campaign for early diagnosis, which is that regular eye exam, that we have, rather than flatlining cataract surgeries, that we actually grow that number to meet the aging population and the demand for those surgeries, you know, and that we properly fund vision research. There are 1.2 million Canadians that the report found that have uncorrectable vision loss. We don't have a treatment for them to restore their sight, and that's why it's so important with the mission of Fighting Blindness Canada to invest in the new treatments that will prevent blindness and restore sight.
A few months ago, we released our cost of vision loss and blindness in Canada study. Today, we've had an opportunity to look at some of the recent startling discoveries we made about the COVID-19 study and how it has had it on vision loss in Canada. We hope that this new information will encourage you to go to stopvisionloss.ca to read the report, to sign the petition, asking the Canadian government to keep their long overdue promise and develop a vision health plan for Canada. You've heard both the doctors and Mr. Earl and Louise Gillis discuss it, but it's important. If you look on the screen, COVID-19's impact on Canada's crisis of preventable blindness. Stopvisionloss.ca. You can read the updates and you can read everything else that you would want to do and sign the petition. So we look forward to hearing from you.
Dr. Mann, in these times of COVID, how are ophthalmologists triaging their patients?
First of all, on an individual level, ophthalmologists, as well as you've heard Dr. Bonsack, our optometry colleagues, are prioritizing patients who could potentially have irreversible vision loss if their diagnosis or treatment is delayed or missed. And so those patients are moved to the top of the list immediately when we're looking at who potentially stayed home instead of coming for their treatments. Then this is followed by those who would suffer the most impact on their lives if their diagnosis or treatment plan was delayed or missed. And so we've heard from Louise very succinctly and well spoken about the potential impact on well-being and some of the difficulties that patients experience when their care plan is interrupted by or has been interrupted by this pandemic. And so patients who would suffer the most impact are also highly prioritized. And then one of the important sort of caveats is taking into account as well the need to maintain equitable access to all patients who need care, not just those who can advocate for themselves and seek that care, but those who may be unable to do so. On a more systems level, ophthalmologists are working with their medical and surgical colleagues and with all the partners in the eye care team to assure equitable access and appropriate access to the resources needed. One example, the COS developed a surgical prioritization tool to provide guidance and support for prioritization of OR time and resources for eye surgery in facilities where there is, frankly, competition with other surgical services. And sometimes, as we've heard, we're not regarded perhaps as being as obviously important as cardiovascular or some other surgeries which are seen as life-saving, but we're certainly no less vital. And so this prioritization tool allows us to play on an even playing field and make the case for why our services are important. In addition, the tool can be used to assist in assigning priority levels to different eye surgeries where there are wait list or access issues to ensure that the equity and access variables are taken into account, as well as the risks involved in delay or deferral of the intervention. So it's tools like that that the COS has supported its membership with, and it's our members on an individual basis who are advocating for their patients to have access to OR time and to the needed interventions. And the triaging that takes place at an individual ophthalmologist's office, we depend on all the members of the eye care team and the referral team to help us with that.
Is your patient load back up to what it was pre-pandemic?
I'm in Nova Scotia, and we've had a much, perhaps one could argue, easier ride during the pandemic than some places. There's some geographic privilege to being stuck out in the Atlantic Ocean, and so we've had lower case numbers and to some degree lower impact. So in my experience in Nova Scotia, that first 2 or 3 months, we reduced volumes, although we never closed. We were there for urgent and emergent care. But after that, we've been able to return to pretty much normal volumes and have not had surgical interruptions here. That's certainly not the case in all parts of the country, and I speak to my colleagues regularly across the country, and in many places, the impact has been much greater, so I don't wish to minimize it by any means, but it has been highly variable across the country.
What does this study teach us about changes that are needed in eye care going forward? Is eye care going to continue being the way it was administered pre-pandemic? What are your feelings about the future?
I definitely agree with the presenters so far, and I think we're pretty much unanimous that this report is really underscoring that the time has come for a national vision strategy, which would provide an opportunity to assess and further improve, changes in eye care delivery. It's a big question, it's a big problem, it needs some focused attention, and I think really a national vision strategy could serve as a platform to address the key challenges and opportunities in vision and eye healthcare in general, as well as the additional challenges brought on by the COVID-19 pandemic, which was identified here in this study. So we believe that the federal government has a role to play, and we feel that this calls for a national vision strategy to ensure Canada's vision needs are adequately met, and including rehabilitation services for vision. The CAO has been lobbying for a long time. And I know that it was supported in a paper released by the Conference Board of Canada in November 2020, which Dr. Colin Mann made reference to. So I think we're all in agreement. We need to change the way the impending increase in patient load is going to affect service. And we need to do that in a focused way. And I think the best way to do that is to do that through use of a national vision strategy.
When you look at a national vision strategy, you talk about virtual examinations and virtual medicine, if you like, being all planned through a vision health plan. We hear a lot about virtual health delivery almost every day, and it's your recommendation that should be taken into account through a plan.
I think it should be part of the overall plan. I think virtual delivery of care is probably going to change phenomenally in the next 15, 20 years. The challenge is that at the moment, there are a lot of diagnostic tests and procedures and imaging that need to be done And so we have to have either access to those images, and ideally at this time, the way technology is at this time, the best examination is done in person at the moment. There are a number of conditions that a person could have that might seem, relatively uncomplicated on the surface if we just see a video or a photograph. I'll give you an example. I saw a patient yesterday, a red eye. Now, if he sent a picture of that red eye, one might presume that he has conjunctivitis. Perhaps he just needs an anti-infective medication. He turned out to have a uveitis, and that's a serious condition that can cause vision loss. And without the in-person examination, really, it would have been impossible to be absolutely certain of that diagnosis. And proper care has to be done at the proper time with the proper tools. And there's much more to a patient than just a series of images. Patients have other issues. They have dry eyes. We have to see how their eye looks with certain vital dyes. We have to evaluate how their eyes work together. Perhaps they have a tendency for the eye muscles not to correlate together. Those are all challenging things that telehealth, teleoptometry, or ophthalmology certainly fills a gap and allows us to address certain needs that are otherwise unable to be met. But there's still a long ways to go. So there's caveats to be aware of for sure there.
You outlined with trials and tribulations that you experience in trying to access care. Do you think that people living with vision loss will still be afraid to have their eyes examined or attend their regular eye doctor's appointment now that COVID is abating somewhat?
Well, I think they'll probably be a bit better on it in some areas, especially in Nova Scotia, as mentioned earlier, where Dr. Mann, we're pretty good here. So I feel that more people will get out and keep their appointments that are booked, especially for injections and regular exams that they have for whatever other eye disease they may have. But there will still be some people who have a fear of getting out because they may have to take public transportation, such as buses or taxis, and they don't know who's driving or who's been in the vehicle before them or in the seat ahead of them. Is somebody carrying COVID there that might have been vaccinated but is a carrier? And those fears are there for many people, regardless of what their eye condition is. So that, and their age being a factor too, in many cases, can often tend for them to be fearful of going out into any public, and many of them stay there. But I'm certainly hoping that now that the majority of people in Canada have been vaccinated and things seem to be looking on the more positive side, that fear will gradually move back into a regular care field, and we get back on track, and within the next 2 years all these backlogs will be cleared off, and hopefully moving forward so everybody gets the best care in the best possible time.
Thanks to research, we know that about 75% of vision loss can be treated or prevented if diagnosed early enough. Our study showed that, as we've talked about, as everybody's talked about, that many people haven't seen their eye doctor, and as a result aren't getting diagnosed or treated early enough. Would you like to comment on the role that research could play in evaluating the new challenges that are presented through this scenario?
I think one of the findings of the original report based in 2019 is that Canada only funded just $21 million of vision research in the country. And when you think that the Canadian Institutes of Health Research, the federal government's research arm in healthcare, has $1 billion budget, I think that says an awful lot around that we need to change the conversation about eye care in this country. There's these almost 1,500 people that experience vision loss, the 1.2 million Canadians that are living with uncorrectable vision loss. Research plays a fundamental role in being able to do those treatments. As you said, 3 out of 4, 75%. If we're able to diagnose early enough, we have treatments. Research has delivered those treatments that are available, and it's critical. In our findings in the report, we saw the number of over 8 million living with a blinding eye disease growing by 2050 to 13.6 million Canadians living with the blinding eye disease that puts them at significant risk. What are the treatments? What are the prevention strategies that research can discover to reduce that number so people aren't at risk? And then when you think about the 1.2 million that today are living with uncorrectable vision loss without changes, without new treatments that research can deliver, we're estimating that number growing to 2 million. Part of the reason why it's not growing as fast as the number of people living with those blinding eye diseases is because of research, delivering treatments and the quality care that our ophthalmologists, our optometrists are delivering. That's why it's so critical that we invest into vision research, that we can, because it is absolutely an amazing moment in time where lab discoveries are becoming treatment. Just a year ago, the first targeted gene therapy approved for humankind was approved by Health Canada. As I like to say, one gene down, 279 to go. And of course, there are many clinical trials happening around the world that we need to bring to Canada. That's critical part of the research process is clinical trials where we do the research in early with small numbers of people. And Canada, those clinical trials are passing us by. So Canadians don't get access to those treatments at the earliest possible stages. We're tracking over 80 different gene therapies that are happening right now in inherited retinal diseases, over 1,000 age-related macular degeneration, well over 500 glaucoma, diabetic retinopathy clinical trials that are happening around the world. They're not happening in Canada. Canadians are not getting access to those treatments. And it says an awful lot. We need to dramatically increase that investment in vision research in this country if we're going to address the challenges of the impact of COVID and for the long term, so we don't experience vision loss when we could discover those treatments to change it.
Dr. Gordon, thank you for presenting the results of your study, but could you comment on the methods used to render the number of 1437 for vision loss due to COVID-19? We made an assessment of the amount of time that having treatment was delayed for the three major eye diseases, diabetic retinopathy, macular degeneration, and glaucoma. And we then went to the literature and had a look at how long, what kind of deterioration untreated those three diseases would experience if they were untreated. And we came up with a number that was a percentage decrease in vision, and then applied it against the number of people that were getting treated in Canada. So it's using literature numbers to look at deterioration, but it is based on real Canadian, on the number of people getting those diseases treated in Canada. Because of COVID, it was harder for volunteers or friends and family to come and support people in going through their mail if they didn't have the strategies in place to do so themselves, though it's still relevant. I guess this is a comment, not a question.
I think in that survey that was done by you and at the Canadian Council of the Blind and supported by Fighting Blindness Canada, we found back in April and May last year that many of the strategies, many of the support services available to the vision loss community disappeared. There was no plans to counter it. So we did find that, people were reporting that they were concerned about their caregiver, their personal support worker coming into their home, would they spread COVID? Them being able to access even, some people, rather than being able to go into a grocery store, they were ordering online for groceries, but the delay meant that they were challenged to put a meal on their table. That was reported by the vision loss community, where access to services did not pivot in order to meet the needs. And we heard from the community, from people living with vision loss, that COVID meant that little edge of independence, that edge of experiencing the world, COVID took that away, especially in wave one, when people were reacting.
Absolutely, and that's why people were experiencing the loneliness they did. Lots of people have family and friends come into their house and do little things for them. They weren't allowed to do that. So it's not just the personal care workers, which it is, which you mentioned, but it's also all these families and friends. And I think that that's what's behind this question. Some of that still exists. I mean, people are not opening up their homes to family and friends. It's going to be a while.
So part of the reason why we still see people not getting their regular eye exam or going for eye health care. If you're experiencing vision blurriness or headaches or whatnot, please go seek care, whether it's to emergency or calling your eye specialist in your community. It's critical. You don't need to lose sight. There are treatments available, but we need to get it diagnosed.
I think the story that Louise told us illustrates an important point, and that is that while people are waiting for care, we have to be very, very careful that we are able to see people in a timely way. And so if you're out there and you have a vision issue and you've been referred, and if your particular area of the country has a delay that is excessive, if you're really having a hard time seeing the ophthalmologist that you've been referred to, perhaps by your primary care provider, your family doctor, or your optometrist, I would encourage you to reach out to your optometrist and see if they feel that you perhaps should be seen again in the interim while you're waiting. Because in many cases, when we as optometrists make referrals for somebody who has a non-urgent case, the situation may change while they're waiting. So if in Louise's case, she was intended to be seen to check her pressures and to monitor her situation, and the ophthalmologist care was delayed, I would hope that many of those people might be able to reach out to their optometrist and be seen and have their pressures monitored to see what's going on. Thankfully, now many of the provinces across this country, optometrists are able to provide care for glaucoma, and they could perhaps help that person with their treatment, or at least tide them over until they see the ophthalmologist that they were intended to see, if that's the case. So I would encourage people not to wait an inordinate amount of time. Reach out to the optometrist in the meantime and see if it would be appropriate for you to be seen while you're waiting for that care.
What message would the panel send to governments across the country?
We are well aligned here on the panel about the need to view things with a national eye care strategy. We've mentioned that in the Vision Health Desk. One of the things that continues to be a problem across the country is the variability in access to needed eye care medications. And so a national pharmacare program, for example, with particular attention to the access to the needed medications for eye health and treatment of conditions. I think, Doug, you spoke about the need for the emphasis on research and making sure that we're prioritizing that. One of the benefits of having been in practice for a long time is that I can see the evolution of care over time and see the benefits that are being reaped by the advances that have been made in treatment of eye conditions. So, I've been in practice long enough to remember when anti-VEGF injections weren't a thing and they weren't available. That being said, it's a miracle. It's marvelous that we have those available now, but the burden of care is very high on patients to get in and manage to get in on a monthly basis, or sometimes extend it a little bit, but to do that. And so isn't it amazing that there's research going on, and hopefully that gets supported and expanded to see about treatment delivery methods. And perhaps, a few years from now, we'll be able to have a conversation about the old days where you had to have injections as frequently as we do now. And there's ways of extending that and treatment delivery methods that are novel. So I think really the message to government is you need to support the eye care team. You need to have adequate training of physician resources for ophthalmology to be able to access the surgical services needed and provide the facilities for those. And we need to consider a national strategy toward eye health in general, but perhaps national pharmacare as well, to allow access to all the needed medications. And that all the underpinnings of those treatment strategies are the research that goes into being able to support those and develop new and novel ways of delivering care.
I think the message that we would send is that there's no time that's more important, more critical than now to put vision care, as a higher priority. COVID has extended the wait time for very important care. The patient who doesn't see well you know, you think of that person who can't see well enough to, you know, to work or to drive or to look after their grandchildren or to be as productive in society as they want to be. That person needs to be seen, and we'd like them to be seen in a timely way. And if this COVID pandemic has taught us anything, it is that delay in care is costly in terms of dollars, and it's costly in terms of quality of life for patients who are waiting for the opportunity to see the way they're meant to see. So this is the time to think about finally making a move towards a federal eye care strategy.
I think first off, it's important to make government realize, as the gentleman before me said, that eye care is important. It's just as important in many cases as cardiac care or whatever, because somebody who is taking medicines for diabetes or other health conditions, if their eyesight is deteriorating, they could make major mistakes in that. And if they can't get access to care because there's a shortage of ophthalmologists and optometrists in the area to do the treatments that they do need, then it's important that we get the proper eye care, and government needs to think more and put it higher up on the list. It's if you break a leg, you know, yes, you do get it fixed right away, and you do get rehab for a broken leg or broken hip, but you get very little of both of those with eye care. So I think it's important to increase that, just so that all the patients around the country can get the best care, because ones who live in the city get far better care than ones who live in the outlying areas. And my previous healthcare experience used to call it North Overshoe. If you live there, it takes days and, you know, quite a bit of time to get to where you need to get to see a doctor. So making ophthalmologists more available in more remote areas, whether they come in on a weekly basis or something or other like that, to improve that healthcare, and that can be done through government funding to allow the ophthalmologists to get the care to the patients.
You know, today Justin Trudeau named his cabinet. So if we were sitting down with the new health minister and the prime minister, what I would say is that 4 out of 5 Canadians, 80%, identify eyesight as the most important ability that they have. And that's not reflected in the prioritization that is happening with healthcare. That's why it's so important to have that vision health plan and to encourage Canadians to speak out by visiting stopvisionloss.ca so that we can send that message to politicians.
Access to care for marginalized or geographically challenged areas and Indigenous populations within our country. I think we alluded to earlier that there have been a lot of innovations made during the pandemic, and some of the aspects of virtual care and telemedicine have been some of those. And I think while it's probably not the easiest specialty to make completely virtual, as Dr. Bonsack alluded to, there are elements of it that can be done as a way of screening to identify those patients who do need more specific in-person care. And so the COS is actively working on looking at telemedicine opportunities and ways of doing research with pilot projects that can perhaps identify those areas in which that may be useful to us to enhance the access to care for marginalized or geographically challenged populations.
I just want to close off with the fact that this report was made possible by unconditional grants from many of the vision loss community's key stakeholders, several of Canada's corporate supporters, and several of Canada's leading research-based pharmaceutical companies. The report's partners would like to express the sincere appreciation and gratitude to the sponsors and their generous support, without which these studies would not have been able to have been accomplished. So we have deep appreciation for that. Thank you very much.